Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum podcast. I'm happy to be joined by Dr. Nikhil Batra, Assistant Professor of Ophthalmology and Surgery at the Dartmouth School of Medicine. Dr. Batra's presentation for this JVRD issue was Belzutifan as the primary treatment of bilateral juxtapapillary retinal hemangioblastoma in a patient with von Hippel-Lindau disease. Welcome, Dr. Batra.
Thanks so much for having me, Dr. Murray. It's a real pleasure.
It's great to have you here also. So you and I both know that within the ocular oncology and retina specialty field, retinal hemangioblastomas on the nerve themselves are sometimes our most complicated patients to manage. So I'm very excited that you were able to put the case together for us. Can you take me through a little bit about the presentation?
Sure. So this is a woman in her 60s. She had VHL, well known for many years. She had had a partial nephrectomy. She's had some adrenal involvement, and we followed her from 2015 forward. She had juxtapapillary lesions in both eyes. In the right eye, it was a lesion that encompassed about half of the inferior aspect of the disc, and it was leading to some minor epiretinal membrane formation, pretty good macular architecture, baseline vision about 20/50. In the left eye, she also had a juxtapapillary lesion, nasal aspect. That vision was good. And we followed her from 2015 to 2022 for about 7 years, and those lesions remained stable. And in 2022, on a routine 6-month follow-up, her vision had dropped to 20/150 in the right eye, the eye with the larger lesion. And we noticed that there was some growth. So there was increased vascularity, there was increased juxtapapillary macular edema, thickening, exudate, and the lesion was leaking more on fluorescein angiography. And similarly, in the left eye, she presented with that nasal lesion, which had also grown. So these lesions, as you said, are difficult to treat. So we were perplexed about what to do in this case. Yeah.
So, Dr. Butler, we've done a variety of different treatments for these. We've talked about external beam radiation therapy. We've used anti-VEGF. There's some argument for steroid. At the point that this progressed, this patient was on no treatment at all from an ocular standpoint, correct?
Correct. These lesions had progressed so slowly and her vision had maintained for so long. All we had at this point was observation.
Yeah. And so you realize as the vision drops, the tumor's larger, the exudate's increasing, you have to pull the trigger and think about doing something. What were you thinking about and how did you get to Belzutifan?
Great question. So full disclosure, I'm not an ocular oncologist. I'm just a country retina doctor up here at Dartmouth. And so I rely on some help from my colleagues. I sought a second opinion from Ivana Kim at Mass Eye and Ear. She very kindly accepted the patient and provided her insights. And it basically broke down into 3 categories. So one was to try intravitreal triamcinolone for the exudative and thickening component of the macular disease. Off-label use of bevacizumab was an option. And then she proposed the idea of using oral Belzutifan because this was working for tumors that were CNS and kidney related. And in conjunction with the patient's oncologist, Dr. Kim, and ourselves, the patient elected to try the oral Belzutifan.
So I'm going to tell you how impressive that is on various levels, because at least within the South Florida community, we have no access to Belzutifan unless it hits a primary indication. And usually that is tumor involvement in the CNS or secondary malignancy, renal cell carcinoma, pheochromocytoma. So I love that you were able to do that for this indication. Did you scan the patient more broadly before you started Belzutifan?
Ocular oncology, they were the quarterback in this case. Patient did have kind of pan scanning before the Belzutifan was started. All of her other lesions elsewhere were stable at this point. So we actually asked her insurance to code this, to accept the code as a primary CNS tumor since it's retina involving, and they did, luckily.
That's a nice insurance company. So we've got to give them kudos because that doesn't happen as often as we'd like it to. So take me through. You've had a good discussion with the patient. This is a relatively new use of a drug. You're using the drug off label. You and I are both really comfortable with that with our anti-VEGF therapies. So not as big a deal for us sometimes as it is for the oncologist. You started the drug, and when did you see the first evidence of a response?
Great question. So the drug was started in March of 2023. And then as soon as a 2 to 3 month follow-up, we saw some improvement. So vision had already improved to 2100 from 2150. There was some decrease in the macular thickening. The lesion itself looked like it was regressing. It was very vascular, juicy, red, vascularized, and it had started to regress and turn into a fibrotic area. Similarly, in the opposite eye, something happened very similar. Yeah.
So that's a huge, improvement. And even in the clinical trial, what was interesting is when they halted Belzutifan therapy, the tumors continued to respond. So it looks like that target can have an extensive impact. And Belzutifan is kind of interesting because it's hitting one of the primary pathologies for development of these tumors, correct?
That's right. It targets the HIF2 alpha small molecule, which is involved in angiogenesis. So it's a very targeted molecule. I'm not the best person to ask about that, the physiology of it, but it seems very well tolerated, actually. The patient, we have actually 2-year follow-up now. This was 2023 that she started this medication. And I just saw her recently, and she's doing great. Both tumors, each juxtapapillary tumor, has completely regressed. She's recovered baseline vision in the right eye to 2050. The tumor just looks like it's fibrosed and dead at this point.
Yeah, so I think that that's exactly the kind of outcome you want for this. We're hoping to get Belzutifan more available for a primary ophthalmic indication that would really benefit these complex patients. For those who don't have access and can't get that through their oncology team, your choice of steroid with an anti-VEGF, both are known to be effective, just not as effective as we would like them to be, as is external beam or proton beam radiotherapy. So we've had options, just all of them were really less than ideal. And this is the first targeted therapy for a primary vascular tumor for us. I think it's really exciting. So you guys really have helped educate everyone on the potential for this to play a major role for our patients with ophthalmic disease.
Appreciate that sentiment. I have a handful of other patients that I also follow with VHL lesions, and we are considering this medication in those patients as well, even for peripheral tumors. So, for example, I have a patient who's lost one eye due to VHL tractional related retinal detachment, and he has a new lesion in the periphery in the left eye. And rather than trying ablative therapy, he was actually interested in the oral option. And so we are going through the process and seeing if insurance will cover it for him as well.
Yeah, I think that's an excellent idea. But one of the take homes for our colleagues listening is when those tumors are small, they are fairly amenable to direct ablative therapy with an anti-VEGF or steroid component. So the key to that is not to let it be a big tumor. And the problem is the tumors on the nerve are unique because we can't apply ablative therapy in the way that we would like to. But I think the idea of seeing if we can extend that indication, I mean, I would love to see more data like this because I think this is really what we would hope to see as advances within ocular oncology and in retina specialty, targeted pathology treatment.
Absolutely. I also I just came across a case report where people are using this as an adjuvant. So they're using Belzutifan short term, try to regress lesions, and then applying ablative therapy with laser or cryo, and that seems to work well too.
So I think you're right. There's going to be a lot of different algorithms potentially of how to do this. And because these patients are relatively rare and the presentations can vary, it's really hard to do a good clinical study. So it may be that a series of case reports like yours or small case series are really going to move the field forward. So for those who haven't had an opportunity to hear about targeting HIF2 with Belzutifan, I think this paper is very succinctly directed at that. So I'd like to thank you, Dr. Batra, for joining us tonight. Great case presentation.
Appreciate it very much. Thank you so much.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.